Hello. Today we are going to talk about a cup. Cup is not a regular cup we use to drink tea or coffee. Cup in medicine we call it cancer of unknown primary. Primary means जो ओरिजिनल साइड होती है कैंसर की उसको प्राइमरी बोलते हैं. कप means cancer of unknown primary. Primary means what the source of cancer, primary cancer, source of cancer. So is the primary source of cancer is eaten up by the strong immune system, that we cannot find the primary. So in other way, it's bad too, that we have to investigate to find the primary, because each cancer has different treatment targets. So it's a good sign or it's a bad sign. So we used to treat it blindly in the past whenever we face a patient with copper. So nowadays we can diagnose 80% of the cup cases in their primary source with the new advances in labs and other things in imaging. Then we can trace the primary source in 80% of cases. So medicine is a dynamic process. It's ever changing, but basic science remains the same. But new technology in the labs and new technology in the delivering the medicine with nanotechnology and inventing new therapies, targeted therapies for chemo. We are able to give chemo without any side effects. So it used to be whenever a patient listens, I have cancer, I have to go through chemo, they will refuse. Just they don't want to feel bad. Bad thing is they feel nausea all the time, vomiting all the time. Nowadays medicine is so advanced, people don't feel nausea or vomiting or loss of appetite. So there are medicine to increase the appetite. There are 4 different medicine, 4 different targets that they can take care of the nausea or vomiting. And you don't feel anything like that nowadays. So especially people who don't have any involvement of liver, any abnormality in the kidneys, or no diabetes, and lung involvement is minimal, and they have a good chances of survival. Not without the chemo, even with advanced cancer, they can live up to, reported in the literature, more than 3 years. So about 15 to 20% of cases, their reports on average can live up to 15% can live up to more than 5 years. So it's a decision patient has to make with the consultation of their oncologist and the primary care doctor, who can provide latest knowledge and the treatments about copper. So patient at their own level should not decide what the future, what kind of treatments are needed. It should be done with the consultation of the oncologist and the primary care, both. So it's a good idea to decide about the future planning, what should be done with the consultation of your primary care doc and oncologist, because there are so many good treatments. It used to be lifespan of 4 to 8 months in the past. That is without chemo, without knowing anything. And nowadays, with good chemotherapy and good medicines, and radiotherapy, immunotherapy, nanotechnology, so much advances are done in oncology, especially in oncology, and then we should avail the technology to take advantage of the new chemos, so that there are 20 to 25, 20% chances of living more than 3 years on average with chemo and radiotherapy. So nowadays chemo is done only within 4 hours on average. They pre-medicate you with anti-emetic drugs 1 hour before, then they start the chemo and they're done in 4 hours. On average, you have to spend 5 hours as an outpatient for the chemo. And then you're done for 3 weeks. After 3 weeks, go for another 5 hours, then you're done. So it's every 3 weeks you can go to the hospital and stay there for 5 hours and come back. And it goes for 6 cycles. So go for chemo and come back home and take care of your business and stay with your family. So no fear of nausea or vomiting or loss of appetite. There are good medicine for everything. And there is maybe loss of hair, which is only temporary. People regrow their hair, even sometimes better hairs come, and people start looking younger than they are. So my question is, suggestion is, you should plan with your family about the end of life care. So what I tell my patients, discuss with your family first, then you discuss with your doctor and the primary oncologist and the primary care, and what you should do, what end of life care. So I suggest my patient, and always suggest, give them the same opinion, and I will be giving opinion in future. Never give permission to your primary care doctor that about DNR. DNR means do not resuscitate. Do not give that permission to write in your chart, medical record. So there are more harm than good by giving that permission. So, for example, if you got simple pneumonia and there are orders of do not DNR, and medical staff may not even put you on simple oxygen. Maybe you need oxygen. When they see the order of DNR, they do not intubate you. If you need simple help, you just go through the pneumonia for 4 or 5 days, or 2 days. And then you get over with the pneumonia. You're okay. It's not end of life. So in that way, if there is a record order of DNR in the medical record, people will shy away from providing even simple oxygen. So I will not give permission to my doctor to write a DNR in my medical record. I don't suggest it even to my patients. So secondly, I give a power of attorney to my dears, to my son or daughter, and give them instructions to stop the artificial sport or like ventilation. When I am in the hospital or on the ventilator for more than 7 days. If you have simple pneumonia, you will get over with the artificial sport within 7 days. If you are lingering on or something bad happens, the sepsis gets bad, then I agree you should stop, give them instruction to stop the artificial sport. Even that person should consult with the ICU doc or the primary care doctor to take away, to stop the artificial sport. So I will also discuss with the family about the organ donation. So body can be used for various reasons, for the purpose of good, for the humanity. So if my organs can be used for any purpose, I'll be happy. So discuss with the organization thing. If my organs are not good, they will not use it. So let the nature take its course. Advances in technology is natural, and everyone should take advantage of the advances. And by not taking the advances in technology, it will be going against the nature. So the advances happens with the consent of nature. And so nature opens up its secrets to the doctors or the scientists only when it thinks that it's okay. They should know this. And the nature doesn't disclose anything that is detrimental to the human being. So God does good things, and we should take advantage of what the God has provided us in today's world. So my close relatives, favorable points in our medical records, whatever I got with me. So she doesn't have an anemia. Her platelets are okay. She has normal liver function test. She has normal kidney functions. She has normal oxygen. She has no diabetes. These are all good, favorable points in our medical record. So I think our plan of action should be in consult with the oncologist. And I will personally, if I will be her oncologist, I'm not, but as a doctor, I am depending on her case. I will recommend radiation to the L2 vertebra and then start a chemotherapy with cisplatin and paclitaxel and bevacizumab. Another name is Avastina. With three medications together, if oncologist agrees to it. So if I have her and it turns out to be ovarian cancer or uterine cancer, I will go for IV and intraperitoneal chemotherapy at the same time. So because it will give me 16 more weeks to live. So even with the more side effects, but I will get to live more, 16 weeks. So prognosis, if your biopsy came back adenocarcinoma, our chances increases by 38 to 50%. So if neuroendocrine tumor or squamous cell carcinoma comes back on histology, then she has even better prognosis. Ovarian carcinoma itself has 3+ years on average chances of survival when she goes for chemotherapy. So if there is no complications arise after chemo with extra care, the complications will be minimum. So intrapleural chemo is not done. I don't know what this is, but in literature it's not done yet. But if they are doing intraperitoneal chemo, and why not? They do intrapleural chemo with paclitaxel. You can talk with your oncologist if you agree to do it, or they can radiate the pleural fusion area with radiation at the same time when they do radiate L2. At the same time they can do the pleural area radiation, or they can intraperitoneal paclitaxel. I don't know, they can do it. New things should be tried. So there are medicine like Marinol. It's very good medicine to increase the appetite. So very good medicine for nausea and vomiting. And the other thing is people grow back their hair. So then there is no worry at all about these minor complications. So I will suggest go for biopsy and chemo in this era of advanced medicine. Thank you. I think and this might help.